Hello and welcome to today's webinar. I am Trevor Smith-Miller, the Communications Manager for the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar. If you are new to our webinar, a little background on our group. CCSN is an organization working with cancer patients and survivors to learn about the complexity of our health system, connect with others to plan action, and act on those plans to create better outcomes and healthy survivorship. Please visit our website to find plenty of information like news, events, and of course, our webinar series. Now, this webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. Now, earlier this year, our partners at Dense Breast Canada commissioned a study to look into the effects of breast cancer screening at age 40 and what happens when screening doesn't happen around that age. A big thank you to them for putting us into contact with our presenter today, Dr. Anna Wilkinson. Dr. Anna Wilkinson is a family physician with a special interest in oncology. She divides her clinical time between caring for medical oncology inpatients and academic family practice. Anna is an associate professor, program director at the PGY-3 FP Oncology program and regional cancer primary care lead. Anna's passion is bridging the gap between oncology and family medicine with knowledge, translation, and investigating impacts of cancer screening to optimize cancer outcomes. In her spare time, she tries hard to keep up with her 4 athletic daughters. Now, Dr. Wilkinson unfortunately could not be here with us today to present her findings, but was kind enough to pre-record a presentation for us today. And so without any further ado, here is Dr. Wilkinson for her presentation, Breast Screening for Women 40 to 49, Why the Controversy?
Hi, I'm really happy to be here today to speak to you about breast cancer screening for women in their 40s, and really hope to explore some of the controversy today. As you've heard, my name's Anna Wilkinson. I work as a family doctor and also as a GP oncologist. And I've done lots of research into this topic, so I'm really excited to be here today to speak to this. My disclosures are that I have had some grants for research. I do get a stipend for being a regional primary care lead, and I've had some consultant fees. And I also want to thank Dr. Seeley for some of the slides that I've used today. So basically, we're going to cover a lot of ground. This talk is in part because it's Breast Cancer Awareness Month, and so just some basics about why do we screen for breast cancer and what is the utility for screening. I'd like to touch a little bit about what is unique about women in their 40s and why we need to think about them, and as well look into what the screening recommendations currently are and what the impacts of the current screening recommendations are based on some of the research I've done. Finally, I'd like to think about what we should be doing for women in their 40s, and I'm going to present my own personal view and what I hope we see coming in the future. So let's get going. So breast cancer, it is so common. It's 1 in 8 Canadian women that will be diagnosed with breast cancer. It's almost 29,000 cases of breast cancer in 2022 in Canada. We know that of those women, 5,500 women will die from breast cancer. And of all the cancer deaths in Canada, it's 14% of those in women. How are we doing with respect to breast cancer? When you look at other countries in the world, it looks like we're doing okay. You'll see in this is the incidence or the number of cases per 100,000 women, and this is the mortality rate. So we seem like we're doing okay. In fact, until you look at the whole list of countries, and you'll see that even though we have a lower incidence or lower rate of breast cancer than some of these other countries, our mortality is worse. And so really, I think we have to think about what we're doing in Canada and what we could be doing better. So we're going to start out by looking just into mammography and breast cancer screening and how it works and why we do it, because I think this gives us a better understanding for women in their 40s. The benefits of screening for breast cancer are that we diagnose breast cancers at earlier stage. So the whole point of screening is to catch breast cancers before they are clinically evident, meaning before you can feel a lump. You want to catch those cancers early So before you can even feel them, so that the survival is better, so that the treatments that you have to have are less intensive, and so that the treatment costs for treating that breast cancer are less. With any screen or with any test, there's a plus and a minus. And so on the minus side of screening, as for breast, as all screening tests, is that it may generate some anxiety. There may be some false positive screens, and there may be overdiagnosis. And so we're going to explore all of these sort of aspects of screening a little bit more in depth. So in terms of earlier stage, I like to think of sizes in kind of concrete ways that you can think about. So this is what, for the different size range here, the different size that you would feel a breast cancer at. And the very small breast cancers, those are ones 1 centimeter to 2 centimeter, are typically those that are detected on screen. So those lumps are small enough that you probably wouldn't feel them. And we know that actually screen detected breast cancers can go down even to in the millimeters. The thing about these cancers is because they're earlier on, typically they're smaller and they've had less chance to spread to the lymph nodes, so that the treatment and the outcome for these cancers is better. In terms of the larger, if you had a lump that was 3 centimeters or 4 centimeters or 5 centimeters, these are typically now at the size where a woman would feel them, and they would feel a lump and go and get that investigated. And so that's called a symptomatically detected breast cancer. And by the time they're those sizes, breast cancers are much larger and they've got more chance of spreading to the lymph nodes, as you'll see with these black dots here. And when you've spread to the lymph nodes for stage 3, the treatments are much more intensive and invasive. And for stage 4, when that cancer has spread to other organs, they're actually not curable anymore. And so really what we want to do is get those cancers when they are smaller and more manageable, more treatable. The outcomes are better. And that's what mammography allows us to do. So here's an example of a screen detected versus a symptomatically detected cancer. And you'll see in the red circles there, this is a very small little breast cancer found on a mammogram, the one in the green on the left, that is typically going to have a very good outcome. On the right, this is an MRI. On the bottom, you can see the contrast in the woman's breast there, and there's lymph nodes there. This is a much more advanced symptomatic breast cancer that's going to have typically a much worse outcome or more invasive treatment. So what is the survival benefit? It varies by stage. This is 5-year survival. For stage 1 or those very early cancers, it's almost essentially 100%. So it's really good outcome. For stage 2, it's about 93% 5-year survival. And then we start to see their survival fall off for stage 3 and stage 4. And so that's why catching these cancers early with screening is so important. We know that mortality from breast cancer has decreased since screening started. And you can see this green dotted line here with my cursor. That's the breast cancer mortality line. And compared to other lines like colorectal, like lung, and like pancreas, you'll see that it has a more downward trending slope. Now, screening began in the late 1980s, and that mortality rate is clearly decreased since then. Part of that is due to treatments, but part is due to screening for sure. In terms of invasive treatments, when we diagnose breast cancers at earlier stage with screening, there is less need for invasive surgeries like a mastectomy, like the one you see in the middle there, and more chance that you may be able to just have a lumpectomy with radiation. So it's a much less extensive surgery, less chance of needing surgery for the lymph nodes in the armpit, less chance of needing chemotherapy, and less chance of those surgical complications like lymphedema that come from those axillary dissections. So really catching those cancers earlier makes a huge difference for women in terms of the intensity of treatments and those long-term side effects that they'll end up with. We just did this study recently that looked at the cost to treat breast cancer. And so on this graph here, you'll see these are the types of breast cancer going left to right, the subtypes. So you may have heard of HER2 positive or triple negative. And going backwards are the stages. So this is green is DCIS, blue is stage 1, stage 2, stage 3, stage 4. And what's remarkable here is that the exponential rise in cost with stage of breast cancer and the huge cost for stage 4 breast cancer, up to over $500,000. And so what we see is that if we can catch those cancers really early, the cost of treatment is so much less. 11 times less cost than for a stage 1 than a stage 4. And so cost, when we have a system, a health system that's very much limited economically, we have to be doing the most cost efficient things for our system. So now speaking a little bit about some of the false positives and the harms associated with screening. So false positives are really around the fact that when you have a screen, you may get called back for further investigations, and that may be imaging and it may be biopsy. And so not all of those women necessarily that you bring back will end up having breast cancers. And so there is a certain amount of anxiety that women may experience. And some of these investigations may be perceived as unnecessary. However, I think we really have to think about how we define false positive, because in my mind, if you're called back for further imaging, you're just being called back for another look and for more information. You're not being told that you have breast cancer necessarily. And so I think we really need to think about false positives in that way. Overdiagnosis is the concept that we are finding cancers and potentially putting women through treatment of cancers that may not have caused them any harm. And this is a really important harm of screening, but I think it's got variable importance when you think of the age of a woman or a man, if we're talking about screening for men. So the most common time that we think about overdiagnosis is prostate cancer. So if you diagnose a prostate cancer in an 80-year-old man who has diabetes and heart failure and lots of other medical issues, the likelihood is that prostate cancer will not be what is going to shorten his life. It's going to be his other medical issues. And so you would have overdiagnosed that prostate cancer because you're giving him perhaps unnecessary treatments and unnecessary worries based on that diagnosis that wouldn't have changed anything. But I think when we look at breast cancer in women in their 40s, this is a whole different ballgame, because really women in their 40s really they don't have a lot of other medical issues typically, and breast cancers are a significant contribution to the mortality. So we'll get into that in a little bit. Anxiety is often raised as a reason we should not be thinking about screening for breast cancer. But I think this is a highly personal decision. And I think a lot of women would prefer to know that they prefer to manage a little bit of transient anxiety with the knowledge that cancer is ruled out with some further tests. I often wonder, we really highlight anxiety in breast cancer screening, but we don't really ever speak about it in colon cancer screening. And I wonder if it's this sort of benevolent sexism that I've heard it quoted as before. But I think the fundamental thing about anxiety is it's a highly personal issue, and I think it's on a case-by-case basis what someone finds anxiety provoking for them. So shifting gears a little bit and speaking about what is unique about breast cancer in women in their 40s, because I think there's a lot of factors that make breast cancer a very important diagnosis in these women that make us have to think about screening. Because as we know, if we screen and we catch these earlier, then the survival benefit is better. You know, why aren't we doing this in these women? So is it a common thing in the 40s? It's pretty common realistically. So if you look at the graph on the right there, you'll see it's like a blue slope of a mountain going up. And that line shows you the number of cases per population. And you'll see that in young women, it's not a lot of cases, but it's a slope that starts to rise. And it's not like you turn 50 when cancer screening currently starts for breast cancer, and then that risk starts then. That risk for breast cancer has been escalating for quite a while. And for women in there that are especially 45 to 49, it's not that far off what the number of cases are in the 50s. So we really have to recognize that there are a significant number of breast cancer cases in women in their 40s. In fact, if you look at the screened population, which is those dark lines there between 50 and 74, the cases in women in their 40s accounts to about 18.5% of those. So it's quite a substantial number of cases. We also know that breast cancer is the second leading cause of death in women in their 40s, and that 27% of the life years lost to breast cancer are in the 40s. So these women, they're dying from this disease, and it's a significant cause of mortality in women in the 40s. What's really interesting, I think, what we don't capture when we talk about breast cancer in women in the 40s is the impact on women in the 50s. Because survival with metastatic or stage 4 breast cancer is quite long and can be up to 5 or 6 years even sometimes. And so many women are dying in their 50s from breast cancers that were diagnosed in their late 40s. And in fact, the mean age of diagnosis for fatal breast cancers is 49. And so that has to be part of the thought process around these women. This graph is interesting because it shows the different impacts of breast cancer on women in their 40s. So on graph A, sorry, I'm just going to have a, we'll see that although the number of breast cancer cases in women in their 40s is not the highest of all the women, so women 60 to 64 have the highest number of breast cancer cases. The middle column is the distribution of breast cancer deaths by age. And then you see that for women in their 40s, their bar is starting to catch up to the other bars. When you look at the last column, which is the life years lost due to breast cancer, again, you'll see that for women 45 to 49, it's actually the highest of all women. And that's because these women are so much younger when they die. So they have so much more life years that they've lost. So there really is a significant impact of these cases. I think really important to acknowledge in this whole discussion is that the incidence or the number of cases in women in their 40s is increasing. And we don't fully understand why, but we've seen definitely a really rapid increase in women in their 30s in the last 5 or so years. And in women in their 40s, since 1980, we've seen an ongoing rise in the number of cases. So we know that it's becoming more and more prevalent in women and young women at that. When we talk about breast screening in women in the 40s, we have to think about all women in their 40s. And breast cancer is different in different race and different ethnicities. And so white women, which is the blue square line there, tend to have a peak onset of breast cancer or peak age of diagnosis of breast cancer at around 60. However, women who are Black, Hispanic, Asian have an earlier peak onset of breast cancer, so down around 40, mid-40s, you'll see there. We know that the mean age at diagnosis for white women is about 62, but for non-white women, that age drops to about 55. And the mean age at death for non-white women from breast cancer is about 10 years earlier than that for white women. So when we're thinking about screening women in their 40s, we really need to be thinking about that individual woman's risk. So is she white and her chance of having breast cancer is more at a later age? Or perhaps she's Black or Hispanic or Asian and has an increased risk of earlier age of diagnosis. The other thing to be aware of is not all breast cancers are created equal. There are typically 4 subtypes or 5 subtypes of breast cancers. And some of these breast cancers are more aggressive than others. So the luminal A, or the hormone positive or hormone receptor positive breast cancers, those are the green parts of those bars there. Those breast cancers tend to be more indolent, more slow growing, and have a better long-term survival than some of the more aggressive or rapidly growing breast cancers like triple negative or HER2. So you'll see triple negative is in red in the graph and HER2 is in purple. And so younger women tend to have much higher rates of these aggressive breast cancers, and women 40 to 49 have higher rates than women 50 to 59. And so when women in their 40s are getting breast cancer, they're more likely to be these aggressive subtypes, which have worse outcomes, especially if they're caught at a later stage. Breast density certainly plays into this as well. Breast density is a measure of the fibroglandular tissue in your breast. And the issue with breast density is twofold. Number one, it makes mammograms less effective because it's very difficult to see breast cancers, which are white, in a mammogram which shows more dense or white tissue. And number two, the presence of breast density increases your risk of developing breast cancer. And women in their 40s tend to have higher rates of dense breasts. This number levels off after women reach their sort of mid-50s or so, but typically much higher earlier on. And here's an example of breast density on a mammogram. You'll see there's 4 classes. There's A, B, C, and D. C and D are considered dense breasts. D is extremely dense breasts. And you get the sense here that it becomes really difficult to find those cancers in a category D, or an extremely dense breast women. And so really what happens is only about half of breast cancers will show up on a mammogram for these women. So because of the higher rate of breast density in women in their 40s, we have to be thinking about, do they need more regular mammograms? Typically women with extremely dense breasts should have annual mammograms. And do they need supplemental imaging? So do they need an ultrasound to go along with this, or an MRI if you happen to have access to this? So we're going to shift a little bit now and speak about why the controversy. I've talked to reporters about breast screening in women in their 40s, and their question always comes back to me: why is this such a debate? Why are people so passionate about this? Why is this such an ongoing discussion? And so I'm going to walk you through some of the reasons why this is as it is, and let you understand a little bit about some of the evidence behind the current recommendations and why there might be gaps in that evidence, and why this is changing. So here's what's happened to the guidelines for screening women in their 40s over time. So annual mammograms were first recommended in 1979 for a very narrow age range for only women 50 to 59. Those guidelines in 1994 and again in 1998 were suggested that women in their 40s not be screened. In 2001, for the very first time, there was a suggestion to discuss the risks and benefits with women at age 40 and decide on screening. However, after that kind of time when it was suggested perhaps to screen women, in 2011, this changed, and it was recommended against screening women 40-49. And this, in the most recent guidelines in 2018, was again recommended against. Now, these guidelines are made by the Canadian Task Force on Preventive Healthcare, and these guidelines kind of make a rule book or a playbook for the rest of the provinces in the country. They take their lead from these guidelines. And what has happened is some provinces and territories continued screening women in their 40s after that 2001 decision, and some provinces and territories did not. So here's what the 2018 recommendations said. They said for women 40 to 49, we recommend not screening with mammography. And they use a 1,000-person tool to speak about the risks and the benefits. So we talked earlier about the benefits and the harms of screening. So they try and put a numeric value on those harms and benefits to allow providers and patients to make a good decision for themselves about what they would want. So these recommendations are currently under review, and we're expecting something late fall from the task force. And this is partially, I think, in response to the US earlier this year deciding to recommend for screening for women in their 40s. So if we're looking at this 1,000-person tool, I think what's interesting to me is these numbers look very definitive, but they're really dependent on the inputs that you use. And so the blue women are the women that would have a false positive test result. The purple women would have an unnecessary biopsy. Their tool says that 7 women would be diagnosed with breast cancer. 3 of those breast cancers would have been overdiagnosed, and less than 1 death would be prevented. So it really, when you see that, you realize, okay, this makes sense, perhaps, that you don't recommend. But there's a lot of numbers that go into this tool. So what kind of evidence are you using for these numbers? How are you accounting for false positives? What's the incidence? Is breast cancer increasing so there's more cases? What's the mortality benefit from screening? And what's the overdiagnosis rate? So let's take a quick look at what some of the evidence is that's currently in this tool, and then we can make our own decisions about what we think. The Canadian Task Force is a very structured guideline committee, which is an excellent thing. They have very high standards. They use randomized controlled trial data. So when you look at evidence supporting guidelines, there are levels of evidence that are better than others. And so the Canadian Task Force, because they're making recommendations for the whole country, use only high quality randomized control trial studies for these 2018 guidelines. So what this means is that within a randomized control trial, you have a question that you want to answer. You have 2 arms, well, in a simplistic version, you have 2 arms, so perhaps mammogram or no mammogram. You randomly allocate patients to each of these arms, and then over time, you look at the outcomes, like perhaps breast cancer mortality, and you look at the difference between the 2 arms. On the other hand, down that experimental trajectory of evidence are the observational trials. And observational trials they're retrospective. They look back and say, okay, we're looking back, this group of people got mammograms, this people didn't. What were the outcomes between the 2 groups, and what was the difference? And it's hard with an observational trial to attribute causality. And you have to be careful because perhaps those 2 groups aren't equal. Perhaps more educated people went for mammograms that had other risk factors which were less, like smoking, those kinds of things. So the 2018 guidelines used only randomized controlled trials because they felt that level of evidence was required and that the level of evidence with observational studies wasn't adequate. But what that meant is, if you look at the dates of those trials, they range from 1963 to 1987. So those are very old trials. Those are trials that are 30 to 60 years old at this point in time. So yes, they are high quality randomized controlled trials, but they are old and they don't reflect current treatment advances, imaging advances in mammogram technology. And I just put this little timeline of breast cancer treatment together, not to go through, but just to show you where these trials sit relative to all these innovations for treatment. So for example, tamoxifen came into broad use in 1984. So these trials were essentially performed before even tamoxifen was around. And there's been many other treatment advances since then. The other issue with these trials is they were done in Sweden, in Scotland, in New York, in really populations that in 1963, 1970 were primarily Caucasian. And so their results are not showing what the benefit would be for a more culturally diverse population like we have today. So these were good trials at this time, and they did show benefit amazingly, even with limited technology, but I don't think they show the true benefit that you would see screening today. And this is a summary of all these trials. The red line in the middle is kind of no benefit, and on the left you'll see screening benefit from screening. On the right you'll see harm from screening. So if you look at all the trials, they land where there is screening benefit. But there are two trials, the Canadian breast screening trials, which showed actually harm to screening. And when you look further at these trials, they've actually been shown to be flawed and have a flawed design. So although this was a randomized controlled trial, there was a clinical exam at intake. And what happened was well-meaning nurses who felt breast lumps during the intake preferentially placed those patients in the mammogram arm, hoping to get them access to treatment. And so the mammography arm in this study had far more advanced cancers than in the other arm. And the mortality rate was higher in the mammography arm than in the other arm. And so this suggests that although we use this randomized controlled trial to get equal groups, in this situation, they were not equal. If we look at these observational trials that just look more at a population base and looking back, there's been lots of them, and these trials all show significantly more benefit than the randomized controlled trials. So they show 49% reduction in mortality. And these trials, although some of them are still old, they tend to be much more recent than the randomized controlled trials. However, these trials were not included in the guidelines because of their design. So if we look overall, the mortality benefit that you get from the randomized controlled trials was 15%, and it was 49% reduction from the observational trials. So shifting gears a little bit to talk about false positives. Again, I think it's really important to differentiate between calling a woman back for another look, a different view. You're not telling that woman she has cancer, you're just saying, you know what, we need some more information. And this is data in this bar graph from the BC program. The blue bar is the very first time someone goes for a mammogram, and you'll see that the recall rate for your first mammogram is probably about 15%, regardless of age, because you're just trying to get a baseline established of what your breasts look like. And then on subsequent exams, probably about 7% of women are called back. The biopsy rate is 1.4%, and 0.36% of those are cancerous. And when you compare that with colon cancer screening, it actually compares pretty positively. So their recall rate is 5%. They have a 5% biopsy rate, which is higher than that of breast screening, and they have a lower cancer rate. When we speak about overdiagnosis in women in their 40s, really, it's not an issue like it is in older women. Women in their 40s are not really dying from anything else other than accidents. And in a recent study we found that mortality due to breast cancer in women diagnosed with breast cancer was about 90% in women in their 40s, dropping to about 48% in women in their 70s. So it really is a key cause of mortality in these women. However, if you look at the numbers that the task force used for their documentation of overdiagnosis, you'll see that they say for women in their 40s, the rate of cancers are probably overdiagnosed between 32 and 48% of the time. So they are saying that anywhere from a third to half of breast cancers are overdiagnosed in women in their 40s, so would not have caused a problem. And yet the number for women in their 50s is only 5%. So why the difference? What's the change? And I think the key is that these numbers, this 32 and 48%, came from that trial that we know was flawed. And so I think I've read lots of studies on overdiagnosis. There's huge ranges, but I've seen that in women in their 40s, typically we think of numbers more around 0.1% or maximum 10%. So what would this tool look like if we put different numbers in? I think we would see 70 women having recall imaging. We would see 10 women having a biopsy, not 43. These are using the BC cancer numbers. We would see 10 breast cancers, not 7, based on the increased rate of cancer in these women. We would see a very low rate of overdiagnosis, almost none. And we'd see a significantly higher mortality benefit if we used the rate from the observational trials and not the randomized control trials. So all of a sudden, the calculation looks really different, and it looks far more appealing to screen these women. So in 2018 and 2011, we said, don't screen these women. What's been the implication of this? We've essentially, if you think about it, we've been running a natural experiment in Canada, unfortunately. So as I mentioned before, some people continued to screen for breast cancer in some provinces, and some provinces did not. And so this is sort of a map of what it looks like or looked like. We can now add New Brunswick to this map as of, I believe, next year. So that's super exciting. But you'll see that BC, Alberta tend to screen, Nova Scotia, PEI, but there's many provinces that do not screen women in the 40s. So if we look back since the guidelines changed in 2011, so since that black arrow, these are the rate or proportion of cases diagnosed at stage 1, stage 2, stage 3, and stage 4. And so since that recommendation changed, we've seen a creep, in the increase of stage 2, this one is stage 2, a decrease in the rate of stage 1. And as you remember from that earlier slide, we want to diagnose these cancers back at stage 1. We've seen stage 3 decrease slowly, but stage 4 increase slowly. And if you look at these same numbers in women in their 50s, what we've seen is a 10.3% increase in stage 4 or metastatic disease in the 50s. So there's a trickle-down effect for women in the 50s. This is what we see in terms of women in their 40s versus women in their 50s. So the red are women in their 40s, the purple are women in their 50s. And essentially, women in their 40s have a much different distribution of breast cancer stage at diagnosis than women in their 50s. So they have less stage 1, more stage 2, more stage 3, and sort of equivalent stage 4. So their stage at diagnosis is less favorable than the women who are screened. So I was lucky enough to work with Statistics Canada with Larry Ellison and Jean-Michel Billette, as well as Jean Seeley, to take the Canadian registry data for breast cancers diagnosed and to look province by province, screener provinces versus non-screener provinces, to say, what happened? What would be the benefit of continuing screening versus not? And I think this really allows us to figure out what would happen if we screen women in their 40s. And we found some pretty remarkable and shocking things, I think. So we looked at, on the left here is women in their 40s, on the right is women in their 50s. And one of the first things we looked at was similar to the last graph: what stage of cancer were women diagnosed at? And we divided the provinces into screeners. And so when you were a screener if you had an organized program with annual recall and self-referral. So women could access this program if they wanted. They would get a reminder in the mail. They would be invited yearly to screen. You were a comparator if you did not have those things. And what we saw for women in their 40s who lived in screening provinces is they had a much more favorable distribution of disease at diagnosis. So they had significantly higher rates of stage 1, significantly lower rates of stage 2, 3, in stage 4 breast cancer diagnosis. And if you look at women in their 50s, again, anticipating kind of a trickle-down effect. So if you're not screened in your 40s, you start screening in the 50s, there's more advanced cancer sitting there because they've not been picked up in your 40s. And we saw that. We saw the screeners had higher rates of stage 1. So this was based on whether the women were screened in their 40s, significantly lower rates of stage 2 and 3 disease. So if you had a screening program for the 40s, your stage of breast cancer at diagnosis was more favorable. We then went on to look at net survival. So yes, there was a stage difference, but did that translate into a survival outcome? And yes, it did. So this is women age 40 to 49. Again, we have our screener group, that's the blue one, and we have our comparator group, that's the red one. And what we see is over 10 years that there was a survival difference for women who were screened in their 40s versus not. And the magnitude of that difference for women 45 to 49 was 2.6 percentage points, which is pretty much on par with the benefit of tamoxifen, which is 3.3 percentage points when taken for 5 years. So it was significant. We were able to look at screening rates because we could look at the Canadian Community Health Survey and figure out what percentage of women were screened in each province. Because just because a province was a screener doesn't mean that all women sort of access screening. And so when we looked at the distribution of stage at diagnosis relative to the percentage of screening, we saw pretty clear relationships. So if you were a low screener, you had lower rates of stage 1. If you were a high screener, you had higher rates of stage 1. And the opposite was true for stage 4. So if you were not screening much, your rates of stage 4 were higher. And if you were screening more, your rates of stage 4 were lower. We also looked at whether survival was correlated to screening participation, and it was significantly correlated. So if you had a lower screening participation in your province, the net survival of women with breast cancer in your province was less. And so you can see that there's quite a trend there. Interestingly, what we found, just looking at the number of breast cancer cases, was if you're screening women in their 40s, the number of breast cancer cases you're picking up is not significantly different between screener and non-screener provinces. But if you are screening women, if you look on into the late 40s and 50s, what you see is that there is more breast cancer in those provinces that didn't screen women in their 40s. And so what that means is that probably in the 40s, we're picking up precancerous lesions or things like DCIS, you may have heard of, and treating those so they never become breast cancers. And so if you think of the cost differential on that first graph, with the DCIS being a tiny little bar, and the treatment of a stage 2 or 3 being significantly higher, up to the 100,000s, there's certainly quite a cost savings here. So the presence of a screening program for women in their 40s overall means less breast cancer for women in their 50s. So overall, what do we know about breast cancer in the women in their 40s? We know that if you're not white, you have an increased risk of breast cancer diagnosis below the age of 50. We know that if you have dense breasts, which are more common in younger women, that's an increased risk for breast cancer. We know that women in their 40s have more aggressive breast cancers. We know that overdiagnosis is minimal in women in their 40s. That women in their 40s who are screened have better outcomes with respect to stage at diagnosis and survival than women who are not screened. So where does this leave us with what we should do for these women? Currently, the guidelines are under review by the Canadian Task Force on Preventive Health, for which we'll be looking specifically at women in these age range. It's expected that probably late fall, we will know what they suggest. But we do know from everything I've heard that they will be considering evidence beyond these older RCTs at this point, which I think is really key, because I think things have changed so much since the 1960s that it's just not reasonable to be basing our guidelines for screening and treatment in the 2023, 24 on something from the 1960s. So that makes me really pleased to hear that. We also know that provinces and territories continue to make their own decisions around screening, but they will look to those task force guidelines to help them make that decision. What do I hope comes out of these guidelines? I hope that there's a recommendation for women in the 40s to be screened annually with mammography, if it's consistent with what each woman wants, because clearly everyone has a different threshold for anxiety. Every woman has a different risk threshold, and that needs to be individualized. I hope that there's a consideration for supplemental screening for dense breasts. And I hope that the provinces and the territories adopt recommendations like this, because the key to really effective screening is to have an organized program where women are allowed to self-refer, because this day and age, with no access to family doctors and so many people without a family doctor, means if you don't have the ability to self-refer, there's a real barrier to accessing this. And the other thing for an organized program is it sends reminders. And I think for women in their 40s who are busy raising families and working, it's one of those things that gets kind of pushed to the back of your mind unless a letter comes in the mail and you realize, oh yeah, I got to do this. I've got to put it on my list of things to do. So this is what I hope for. I think we will see. I'm very hopeful, certainly, that there's been a lot of research, and I think really my views on this are shaped by the research that I've done with Statistics Canada, where I feel like we have real evidence for what screening in the 40s has done for breast cancer in these women. So thank you very much. I hope that I've given you a really good overview of what breast cancer screening is all about and what breast cancer screening in women in the 40s is all about.
I would like to thank Dr. Wilkinson for that presentation. It was a fantastic way to kind of show the issues about that. So thank you very much to everyone who has joined as well. Now, normally we'd have a Q&A session, but as this is not a live session, you can post your question down in the chat, or questions can be directed through me through the copy of the webinar you will receive in your email. I will then take those questions and send those over to Dr. Wilkinson, and I will send the answers back over email. I'll be around for a little while to collect those questions so that I can give them to the doctor. Now, this is one of a series of webinars that we are presenting this fall. Our next one is actually happening next week, so to stay in the loop about webinars, visit our website or check your email for our e-blast. If you're not seeing the email in your inbox, check your spam folder, because we do use a third-party email service. And if you subscribe to our newsletter, you will be in the loop with all of them, or you can go to all the webinars at survivornet.ca or on CCSN's YouTube channel. So once again, thank you very much for attending the webinar, and I will be sticking around to take questions to forward to Dr. Wilkinson. Aside from that, have a fantastic day.